metaphor to talk about it in ecological terms. So we get ecoflammation in the environment. And again, I had a paper published on this in which I used this picture last year in Obesity Reviews, where I was talking about climate change as being a form of carbon resistance in the atmosphere, just as diabetes is a form of insulin resistance at the biological level. And of course the two are related, as I talked about right from the start. They're both related to economic growth, both biological and ecological. And so climate change and health are intimately related. This is the form of ecoflammation. If we do that traditional epidemiological analysis, we start off with the diseases, and you start off with a biological pathology here. It might be diabetes, cardiovascular disease, cancers. You go to an ecological pathology down here. Then you take it back to the risk factors, the markers, and you've got metaflammation, insulin resistance, obesity up here. You've got ecoflammation, carbon resistance, global warming down here. And you keep following that back, and you get the similar distal cause. It's industrialisation, population growth, economic growth in particular, that's causing both climate change and chronic disease. We can't divorce the two. So, just quickly, what can we do about this? Well, most of you work in the clinical area, and so it's difficult for you to even conceive of doing anything at an ecological or an environmental level. But it is important for you because you people in primary health care in particular have access to so many people that this is almost a form of public health, that we have to get this knowledge out to the patients as well. And is there something that we can do that might cope with both the biological and the ecological inflammation that we've got? Again, I made a suggestion on this based on what the English are looking at the moment, and that is personal carbon trading. Now, the basis of this is that chronic disease, energy use and climate change are all interconnected. I hope I've made that message clear. The average Australian New Zealand carbon emissions are 16 tonnes per person per year, and that ranges between about 2 and 20 tonnes. Now the Chinese, to give you an indication, the Chinese now emit 2 tonnes of carbon per year. There's 1.37 billion Chinese. The Americans emit 24 tonnes per year. Every single Chinese wants to be like every American. So if 1.37 billion emit 24 tonnes, we are all in deep doo-doo, basically. The sustainable level is what the Chinese are doing. If the whole world, 7 billion of us, were to cut back to 2 tonnes a year, it would be sustainable long term, forever. How do you do this? Well, one way of doing it is, they've talked about carbon trading at the industrial level, but carbon trading, industry is only accountable for 50% of carbon trading. The other 50% comes from us, individuals and households. And so the suggestion is that you develop a system of personal carbon trading where you develop contraction and convergence. Contraction means that every year you get to burn less carbon units individually, but you can profit from it, as I'll show you in a minute, if you don't burn your carbon units. And the convergence means that the rich and the poor start to come together because we're all in the same boat as it comes through here. So what does it mean? Carbon quotas are allocated to everybody, and this is on a credit card like you get on your Master's card or your petrol card or anything else. They're allocated to everybody over 18 years of age based on a set quota per year. So we emit 16 tonnes now this year. We need to go down to 15 tonnes next year, and then 14 tonnes, and so on in the future. Now, what you can do with your carbon units, because they are given to you for a quarter of a year or a half a year or a year, is that if you don't use the units you're given, you can actually sell them back into the carbon bank. And the carbon bank is just the ordinary banks. And you can make money out of it. So that if you're frugal, you actually make money. You lose weight and you make money. If you are not, and you use a lot of air conditioning, you drive big cars, you use a lot of energy, then you actually expend all your carbon units and you have to buy more. But as the allocation goes down, the price goes up. It's like ordinary carbon trading, but it's used with individuals. These are tradable based on frugality, but with price and extra units rising according to demand. And reduced energy use and increased personal energy use would result in reduced obesity and climate change. Now, again, this is not just my idea. This has come out of the United Kingdom, and in the United Kingdom it's actually gone through Parliament, and they are discussing it quite seriously. I can't get newspapers in Australia to look at it, apart from the Medical Journal, in which I published an article. One of the things that I said in that article was what we could expect from personal carbon trading is not necessarily the drop in carbon. It's the change in attitudes to consumption, which is the important thing, the most important thing. As Sir Bernard King, the United Kingdom chief scientist, said when he was asked at the end of a speech in England by a young, attractive lady, "What can I do to reduce my carbon footprint?" He said, "Stop admiring young men who drive Ferraris." The newspapers picked it up and blasted him for having a go at Ferraris, of course, but that wasn't the point. He was talking about the attitude to consumption. It's our attitude to consumption. Those of you who are old enough, remember back in the 70s, the hippie era, we had a totally different attitude to consumption. But that all went out the window in the 80s when we found new oil, and also from pressure by the politicians and certain religions and so on. So it's the attitude that we need to change, and my view is that personal carbon trading will change that attitude. Let me just finish up then by talking about lifestyle medicine, where it fits into conventional clinical and public health dichotomy, and what it adds to conventional pharmacomedical treatment. And I need to reiterate what Norman was saying. There's absolutely no idea that what we're talking about here in the Australian Lifestyle Medicine Association, that we replace conventional medicine. That's not the idea. This is adding to conventional medicine to take account of the changes that have occurred in health over time. Now, if we look at the current system on two scales, public health and individual health, and early prevention and late prevention. Health promotion, we're pretty good at health promotion in Australia. We were the first to legislate seatbelt use, to legislate swimming pool fences. We've got the biggest drop in smoking, apart from California, in the world at the moment, largely due to one or two very diligent people, but we're quite good at that. Conventional medicine we're also very good at, but it's up this end of the scale. We're dealing with, we don't get, particularly the men that I work with, we don't get them into doctors before they get sick. It's not prevention, it's not primary prevention anyway. So there's a gap there in between that, but what's missing is this bit in the middle, the lifestyle medicine, the bit that links clinical medicine and public health. What is lifestyle medicine? Well, it's the application of environmental, behavioural, medical and motivational principles to the management of lifestyle-related health problems in a clinical setting. And the key thing here is the environmental, behavioural and motivational. And I'm going to be talking on Sunday on motivation. I think that's one of the key aspects. It's interesting, if you look at all the NH and MRC grants that go out every year, and if you look at all the conferences, John and myself and a few others were involved in organising the World Obesity Conference in 2006 in Sydney. Out of about 1,200 papers that we reviewed, there wasn't one on motivation. Not one. And how can we deal with health problems, particularly lifestyle-based health problems, if we don't give money to research on motivation, if we don't support the views on motivation? And I hope there's some psychologists in the room that are able to do that. There are some pretty basic principles of good health, and I always say that exercise and nutrition are the penicillin of lifestyle medicine, and psychology is the syringe, if you like. But then when we started writing the book on lifestyle medicine, we realised there's much more than just exercise, nutrition and weight control. There's a whole range of other things like stress, sleep, sexual behaviour, teeth, and a whole range. Pain is another one as well. And here's a list here of just some of the things. Iatrogenesis, we have Julian Henwood on Sunday, who's a pharmacologist, talking about iatrogenesis and the appropriate use of medication in lifestyle-based diseases. I mean, what's the point in describing an antidepressant for somebody with mild depression if it puts on weight in a woman and makes her depressed, or if it causes erectile dysfunction in a man and makes him depressed? We have to look to the alternatives to be able to add to that. Where does it fit in, this lifestyle medicine? You've got acute disease and chronic disease, and these days there's a bit of a blur because you get diseases like AIDS that are acute diseases but have become chronic because of medical intervention. You get cystic fibrosis, which is out the other end here, a genetic disease which is not a lifestyle-based disease. But largely there's about 70%, and it's mainly chronic diseases here that are lifestyle-based. About between 60 and 70% in Australia of visits to a doctor are there because of a lifestyle-based etiology, lifestyle-based cause of disease. And that's why the need for an association like this. What's the difference between the two, conventional medicine and lifestyle medicine? This is the list that Andrew and Stefan Rostner and myself drew up over time. And I won't go into this in detail, but you can see that the lifestyle medicine, and again, one's not replacing the other. It's integrated into the other system to make it much more holistic. There's an upstream focus in lifestyle medicine. It treats lifestyle causes. The patient is required to make big change. It's not as easy as just giving a pill to a patient. and therefore the patient really has to be motivated and the treatment becomes longer term.